Hi, it's Dr. Mann, OBGYN and lifestyle medicine. Today I want to tell you a story about a discussion I had the other day with one of my colleagues. This particular colleague has an additional board certification in high-risk obstetrics. I was talking to this doctor about the incidence of gestational diabetes in our community and also the increasing number of pre-gestational diabetics, especially what we call type 2 diabetics. What does that mean? It means there are women walking around who were diabetic before their pregnancy and they didn't even know it, because a lot of women don't go to the doctor unless they're pregnant, especially in the reproductive age group. So what happens is they come for their prenatal visit. We order hemoglobin A1c. We find out it's in the diabetic range or in the pre-diabetic range. And now we have a bit of a mess on our hands, because that implies that they've been diabetic all along. They're walking into their pregnancy already a diabetic. So I had such a patient come. She actually had a miscarriage. And we used that opportunity to look into her labs, and we found out that she was a pre-diabetic. So I said to her, listen, I understand you want to have a baby, but your hemoglobin A1c is 6.0. That means you are a pre-diabetic. Why would you want to enter into a pregnancy with the state of pre-diabetes? You might become a frank diabetic during pregnancy because glucose tolerance usually worsens in pregnancy. And why would you want to do something like that? So this high-risk doctor said to me like this: she's allowed to become pregnant with a hemoglobin A1c of 6.0. And I held my tongue. But what did I want to say? And why did I hold my tongue? That's a different story. It's called politics. But what I wanted to say is like this. Let's say this woman has a hemoglobin A1c of 6.0, which is pre-diabetic. Diabetes is 6.5 and up. Why are we so concerned around the time of conception about blood sugar control? Well, we know that diabetics have a higher incidence of congenital anomalies. Their babies can be born sick, unwell, with certain deformities or birth defects if their blood sugar is out of control. So we can say with reasonable certainty that someone who has a hemoglobin A1c of 6.0, that they are not really at great increased risks for congenital anomalies or birth defects. But what happens on the other end? What happens at the end, in the 9th month? What happens if the woman becomes a frank diabetic during pregnancy? She might have to go on medication, insulin or metformin, which is a pill. And then we start the fetal surveillance because we're worried about placental function. And we know that if someone has normal blood sugar, their placenta is going to function just fine. And we know that women who gain excessive amounts of weight or eat a diet that is full of ultra-processed foods or foods that are high in sugar, refined carbohydrates, etc., those women are more likely to have a bigger baby. And we know that women who have some degree of glucose tolerance may wind up having a bigger baby. And what's difficult about a bigger baby? It's harder to push out. It increases the risk of cesarean. It increases the risk of induction. And again, getting back to the possibility of moving into the frank diabetes category, besides the risks of macrosomia, which means large baby, again, we're worried about placental function. We're worried, God forbid, about losing the baby in utero, which is one of the worst things imaginable. So what happens if we start to see things are getting out of control with the size of the baby, or maybe the amniotic fluid is excessive? We may recommend an induction. And what happens to a baby that is induced before its time? maybe it's not going to breathe as well, or maybe it's not going to suck as well, or maybe it's not going to hold his temperature as well. And if the mother has high blood sugars towards the end of pregnancy, the baby is used to a high blood sugar environment, and then when the baby is born, the blood sugar drops, and then the baby cannot maintain its blood sugar and it's transferred to the neonatal ICU. So why am I telling you all of this? Because of that one comment that I received from a high-risk obstetrician telling me that a patient with a hemoglobin A1c of 6.0 shouldn't have any problems becoming pregnant, but we are not thinking about the entire pregnancy when we're making that statement. And that's why I counsel patients that they have to get out of the pre-diabetic range. If it is within their capability to do so, they should try to get out of the pre-diabetic range in their hemoglobin A1c before they attempt a pregnancy, because at the end of pregnancy, they will avoid all the chaos and the possibility of delivering their baby by an induction, which also might fail and lead to a cesarean, which is also not good for the baby for many different reasons. So listen carefully. Try to fix your diet before you become pregnant. If you are pre-diabetic, try to get in to the normal glycemic range, and then you're setting yourself up for an easy pregnancy without an excessive number of sonograms and excessive fetal surveillance and an induction, which is an unpleasant experience and not necessarily good for the mother or the baby. When you need it, you need it. But why should you set yourself up for needing these things when you could simply avoid them? Good luck.